My name is Geraldine Strathby, and I have the huge privilege to be the hostess for this discussion, 1 hour type discussion on COVID and the impact it's having on people at the front line. You will have read many articles on COVID, watched many TV programs, many government broadcasts, seen the views of experts from all over the world. But what this session about is learning from the people who have been and continue to be at the absolute sharp end in inpatient services in mental health. We're joined today by a panel of experts, people with lived experience of mental ill health, wonderful head of psychology, junior doctors, fantastic nurse who leads a lot of our practice at SLAM, and Dr. Maudsley Smith, who is our national expert in all sorts of things, including particularly equalities. So I'm going to start this session by going to our panelists one by one and asking them to introduce themselves and just talk for 5 minutes or so about what's been the experience for you of COVID, personally, professionally, on the people around you. What have you learned? What do you want us to know about what it was like to be you during COVID? So can I start with Marcus?
Of course you can. Thank you very much, Dr. Strathby, for the nice introduction, and thank you everyone for having me on the panel. My name is Marcus Tan. I am a junior doctor. I am a cancer registrar at the South London and Maudsley. And during the COVID time, I was working in what's called the Bethlehem Adolescent Unit, which is essentially the only CAMHS inpatient unit that was open during this time. I didn't know if you want me to talk a bit more or not.
It would be, yes, why don't you continue with your experiences, Marcus? That would be great, thank you.
Of course, sure. I mean, yeah, I think, CAMHS was a very unusual time, and not just because of the fact that it was COVID and kind of everyone had to deal with isolation. I think that did manifest in the fact that, for example, the way I think about it, that were kind of, there were the patients that were directly affected and also kind of the wider ward services. I think the way the patients were affected and kind of like one of the things, for example, that was quite common for them was the fact that leave was quite restricted. So they couldn't go on unescorted leave anymore, which I guess for those who don't know what that means, essentially that means that if we as doctors decide that they're safe enough to go outside the ward, outside the hospital grounds for a period of time, that actually couldn't happen anymore. Not on their own anyways. There was still some unescorted leave with parents. But like, say, for example, if they wanted to take the trip down to the park, that couldn't happen anymore because there were social distancing rules and all that in place. It also affected visiting as well. And I think the parents were absolute troopers at that because, obviously it must be so difficult, the fact that their children are away. They can't visit them, possibly in a very strange environment, possibly for the first time. And they're told, because of social distancing and risk of infection and all the rest of the very sensible reasons, unfortunately, you can only visit your child for, I might be getting it a bit wrong, but I think it's something along the lines of not much more than 1 hour every week, and they need to book it in as well. There were, of course, kind of iPad conversations that happened, and there wasn't really much of a limit to that as long as there were devices to go around. But no, yeah, that happened, and unfortunately, yeah, that was one of the things that had to happen to them. And I think there was also the aspect of them, they were trapped in a bit of a bubble, actually. And I think, I suspect all the inpatient units are like this. Like, you're put in this very self-contained environment where you don't have that much access to the outside world. You don't have, unlike us, we might have our smartphones beeping notifications at us every day. But yeah, which they do have smartphones to an extent, but certainly kind of like they don't see the news, they don't hear the perspectives of everyone else. Their focus is on getting better, rightly so. But as a result, they might just, I think some of them were kind of, when we told them you can't go out because of COVID, I think some of them were a little bit skeptical until we actually sat them down and kind of, showed them had a bit more of a chat about the evidence at that. So I think that was quite interesting. I mean, I think in terms of the ward environment, the other thing I will say as well was the fact that, like I said, a lot of wards had closed. So to give a bit of context, the Maudsley, South London and Maudsley NHS Foundation Trust normally has 3 inpatient units. One of which is a children's inpatient unit, that's for ages, I believe it's 6 to 12, and 2 adolescent units, that is for the ages of 13 and until just before 18. The children's unit closed, that was before COVID happened, and also the other adolescent unit, which is called Snowfields, that closed as well. Snowfields actually closed due to reasons related to COVID. I think, I'm not exactly au fait with why exactly, but I think it was something along the lines that they were trying to repurpose it in case like King's College Hospital needed more beds for very ill COVID patients. So yeah, that happened. And yeah, it was very interesting because from camps, all of a sudden, I mean, there's so it's the bed pressure, isn't it? All of a sudden, kind of, as camps were destroyed from kind of essentially what was, I think it was 18 or possibly more, probably more than that. From having more beds, there were very few beds available, and just kind of having to work with that. And the fact that kind of like the beds filled up fairly quickly, and when they filled up, where did the patients go as a result? And yeah, and then there was also obviously the rest of the other COVID kind of effects that I'm sure everyone else will talk about. For example, doctors going off sick. For us, possibly made a bit kind of mitigated a little bit because of the fact that the children's unit people, that the staff, or at least the doctors, they moved downstairs to work in the adolescent unit. I was one of those people actually. So I mean, even though there was staff sicknesses at the start, that mitigated it a little bit. Yeah, but then also again the fact that 2 teams merging, so there's managerial issues in terms of that, making sure 2 teams can work together and effectively, and kind of making sure there's strong leadership. Our consultant did a really good job of that as well. And also again, staff sickness. The other thing, the staff there was quite kind of nurses and all that as well. Yes.
Thank you very much, Marcus. You've given us a great picture of what it felt like to be a young doctor on a ward, the closures, trying to deal with that, the concerns about people and their liberties. Let me turn then to Lewis, who is a nurse, and we often know that nurses are the people at the sharpest end, often in mental health, and in fact in all of healthcare services. Lewis, what was it like for you?
Thanks, Geraldine. Yeah, so I'm a nurse. My role within the trust is as the lead nurse for reducing restricted practice. So day to day, it's around working with teams, frontline teams on the wards and in some community settings as well, to think about how we can apply the principles of working to the least restriction possible, providing good quality care that really taps into what that individual needs and helps them to sort of build their own resilience so that we're not having to use more restrictive elements such as restraint or seclusion or anything like that perhaps people that are listening in aren't familiar with. So I think one thing to say is that my role as a nurse is trust-wide. So although I'm working frequently with teams, I'm not currently placed directly in a ward setting. So I think it would be a bit disingenuously for me to say that I was really on the front line experiencing what many of my nursing colleagues really did. But obviously I got an overview from speaking to the teams throughout the course of the pandemic. And I suppose one to kind of talk through it in order. One observation, and it's kind of interesting, normally I would share an office with our infection control team. That's where I happen to sit. So in the run up to moving towards when lockdown was coming in, I felt like I could see this wave coming towards us that everyone around us hadn't quite realised what was coming yet. So it was sort of this stage of almost, it's not going to be as bad as we think. So quite early on, I felt like I was starting to think about what are the ramifications for this. And as Marcus has said, how do we run our services? How do we deliver basic nursing care if we don't have the staff to do it? If 70–80% of our workforce goes off. And that was kind of one initial observation. Then there was a weird period around the time when the lockdown came in where in my world, things went very quiet. I think think it was just this adjustment period of nursing teams having to suddenly realise what is the new way of working that we suddenly have to throw ourselves into. And I think that's been a general observation. I've been so impressed, particularly with my nursing colleagues, about how quickly they've been able to adapt to new ways of working. Because normally I'm the sort of person in my role, I'm going around trying to push them to change their practice and develop. And as with any change, people don't like it, so it takes its time. So I was incredibly impressed with the pace that they were able to do it and the resilience that they demonstrated throughout doing it. I think there was something as well around the concept of isolation, and I'm not sure whether, I think that sort of sat differently within mental health services than perhaps it did within our acute colleagues' settings, in that we are used to applying restrictions to people under certain circumstances and under certain legal frameworks. And I think we probably had a period of time where we were working within what we were comfortable and used to working with, i.e. under the Mental Health Act or under the Capacity Act, and applying those restrictions, but for a different purpose that actually probably wasn't always completely covered, and giving us the right to do that under those. So there was some work that we needed to do quickly as a trust to really understand how we could continue to uphold people's basic rights and make sure that we were fundamentally still working in a least restrictive way. Another observation, I suppose, is on a kind of personal level. It was trying to sort of understand how my role fitted within this new setting. So, like I said at the beginning, it was quite quiet, and it struck me that what had been a subject that was quite probably at the top of the Trust's agenda in terms of a challenge and something that we wanted to improve on had slipped down, and how do we still keep that good work that we were doing going and keep the momentum there and keep people thinking about what is it to work to reduce restricted practices, how do we think about the person as a whole and their life context of what they're experiencing now. There was something else as well, I suppose, on a more personal observation. So speaking to family or friends, and they were sort of saying, "Oh, how are you affected within the mental health setting?" And it occurred to me that the general sort of perception was that people within mental health settings wouldn't be affected by COVID, that it was going to be business as usual. And they were surprised to hear that we were having numbers of people that were testing positive, that we'd had a number of deaths, that we'd had to close wards and fundamentally restructure our whole healthcare system or mental health care system. So I think that was kind of a key observation.
Well, that's really, really helpful. So, Lewis, you covered the shock, the rest of society thinking mental health could just go on doing its business, and COVID would impact on us, how it impacted on our restrictive practices, people being able to go out on leave. That's kind of really, really rich. So let me turn first then to Philippa, who is our expert by experience, and an amazing resource that we have in SLAM in terms of the insights that she brings. I should say Philippa sits as the expert by experience on the Mental Health Law Committee and keeps us completely grounded. So could I turn to Philippa and then go to Al and Laddie? Philippa, tell us, what was it like for you and your colleagues or your peers?
Yeah, for me, I had just got back from hospital when COVID hit. I spent Christmas and New Year as an inpatient on an inpatient ward. I could see COVID happening in China, and probably along with the rest of the population thought, it's in China, meh, not going to come to here. SARS didn't, why should this come? I came home and then suddenly found all these restrictions suddenly happened. It was probably within a week that everything occurred. That I was told, because I was doing service user stuff with South London and Maudsley, I was told, don't come in anymore. My housemate went to live with her family, so to look after them. So my friends were all working from home. My family aren't nearby, and have limited family. So there I was, just having been discharged from the home treatment team, and suddenly my world has just ended, because I have no job. I have none of the things that would normally keep anyone sane, let alone if you're still mentally unwell, because you don't get discharged when you're well. You get discharged when you're well enough to vaguely cope with being out of hospital somewhat. We might see you back, we might not. So I wasn't well, and I was stuck with all these massive stressors, which in their own are enough to give people symptoms of mental illness. And I just fell apart. I stopped eating. I normally do an online shop, and because I'm not vulnerable immunologically, I'm only vulnerable mentally, because I have a history of anorexia and I have social anxiety. So I normally do online shops. I was at the point where I couldn't really leave the house, but I was expected to go do a COVID online shop, COVID face-to-face shop. I ended up lying on the floor in the middle of Tesco in the aisle because I'd just been told off for doing the one-way system the wrong way. I just remember just lying on the floor crying because I could not take it anymore. There was no more I could do. I couldn't get hold of my medication. Because you can't talk to the GP. I couldn't get hold of my care coordinator because they're not at the care coordinator place. They're in their house, wherever that is. It was horrific. And then I was hearing from friends and seeing friends who were in hospital. And I saw people going to A&E for self-harm and then coming back to the ward and being put on a 14-day isolation. And I saw that their mental state deteriorated over those 14 days of isolation to the point where at least one person I know ended up in ICU. And that was it for me. That was like, this is going to kill me. Not COVID. This is going to kill me. This trying to keep me safe from COVID is going to kill me. And went online. What am I qualified to do? I have a background in healthcare science, so I signed up as an HCA. I signed up at Barts, which ran the Nightingale Hospital in London, and I applied. And obviously I've got all the qualifications, so it was fine. And I'm now working in Barts. But that was the thing. COVID has a 2 to 3% chance of killing me. My mental illness, probably 33% chance on a normal day. It was getting up to being 80-90% chance of killing me. I was going to die, and not because of COVID, because the effects that COVID left throughout the rest of the population.
Well, as always, thank you so much for just giving such an amazing perspective, completely grounding us. Insights that I think I'd love to see you on one of those Prime Minister broadcasts talking about, well, what actually is COVID? What is the real impact of COVID on mental health? Al, can I turn to you, our champion of human rights and psychological therapies? I think you're on mute. Brilliant.
Thank you. Thanks, Geraldine. Thanks for inviting me. Thanks for helping me with the technological challenges. I'm Al Beck. I'm the Director of Psychology and Psychotherapy. And and thank you, Philippa, for what you just shared, because I think that what you shared is actually what 99.9% of the population feel, but probably aren't brave enough to say. So thank you for being brave enough to say it. And I think that we're all affected by COVID, and most people will be touched by anxiety. Not everybody will experience it to the extent that you have described, but most people will find themselves in a situation where they haven't been able to cope as they usually did, and that was true for me as well. So my job is to lead psychological therapies across South London and Maudsley, and before the pandemic hit, my job was to be increasing access to psychological therapies, because that's the long-term plan for mental health. And it's a challenging one, because psychological therapies are many different things to many different people. And I think COVID has taught me a lot about what psychological therapies need to be. So psychological therapies, I think, in most people's minds, are a place that you come to receive an intervention from an expert who will teach you how to think, feel, and behave. And I keep looking over my shoulder for that expert to come in the room and teach me how to think, feel, and behave. But unfortunately, the door's locked, so she can't get in. But I think what the pandemic's done is really brought to light just how we need to be doing that in a different way for me. So I'll give you an example. When the pandemic hit, and it did sort of come out of the blue, as you described, Philippa, we did know it was happening over there in China, and for some reason that I now can't explain, didn't quite accept the reality that it was going to come to us, and really quite quickly. So when it did, I was tasked with setting up services to support staff in the organisation, and that's kind of no mean feat. But I thought, well, I know this business of psychological therapies. I've been doing it for years. What we'll do is we'll offer people psychological therapies, and they will come gratefully to us and say, thank you very much, I would really like some help with my anxiety, depression, the other conditions that I'm suffering with. And lo and behold, they didn't do that, because frankly, none of us want to be acknowledging that we feel anxious or depressed, or any of the mental health problems that we have. I mean, worrying about my physical health, overly worrying about my physical health, overly worrying about other things, becoming angry, drinking too much, taking illegal drugs, sleeping with people I didn't think I should be sleeping with. All sorts of things are manifestations of dysregulated mental states. So what we quickly realized was, instead of the very prescriptive approach that we have to psychological therapies, we needed to go to people where they were at, and we set up what we call decompression hubs. I'm not quite sure why we called them that. I think that's a term that's borrowed from the army, that sort of somehow or some other source that only is a poor metaphor for mental health. But it's basically a space where you could come and sort of unwind. And do that informal human connection. And that seems to be something that got quite lost with social distancing and the emphasis on infection control. We all had to keep away from each other, and somehow that was supposed not to infect or increase our worry, but of course it did increase our worry. So we set up these spaces, and we found that we needed even better ways of encouraging people to connect with one another. We didn't want to be requiring people to ask for psychological therapies. We need to make it possible for those to happen by the back door. And that's the big lesson I've taken away from this. The big lesson is we have to do that in everything that we do. Why should a service user have to come and say, I've got a real problem, I need your help? It's patronizing. It puts us in a different power relationship, and it suggests that one of us has an expertise around psychological therapies, and that's the woman that's about trying to get in my door at the moment, and the other one has to receive it. So the things that have really worked well in terms of being able to support staff during this pandemic, I think, are the ways in which we've been able to introduce people to the simple ideas of stress management. And those are things like stay connected to people, make sure you have a good, healthy diet, healthy exercise, make sure that you have opportunities to give, not just to receive. That's something that mental health professionals, social care professionals do exceptionally badly, because we all have a great wish to help other people, but very poorly developed skills to receive help from other people. And so building in that stress management by the back door has, I think, been the biggest lesson that I've learned. And it's been actually a real interesting journey, I think, for me. And I'd love to talk more, I think, about how we can work together to build those lessons in going forward.
Thank you very much, Alan. Absolutely fascinating perspective I don't think I've heard yet. Hearing many things I haven't heard, I haven't seen in all the Twitter feeds and all the national conversations. So thank you for that, and we will come back to it. Lade, from your perspective, thank you very much for joining us.
Well, thanks for inviting me to speak. So, so I'm a clinical director for forensic services at SLAM. I'm a consultant psychiatrist, and also I a recently appointed race and equality lead for the Royal College of Psychiatrists. And actually, I also happen to have a special interest in physical health, particularly for people with severe mental health problems. And what's interesting is right at the beginning of March, we were at the Forensic Faculty Conference, and it was a bit thin on the ground. And it's interesting what Philippa says about, people thinking, well, this coronavirus, it's something that's happening in China, it's not going to come over here. But at that meeting, there weren't so many people as you'd expect. And a couple of the speakers, one of whom was in Milan, the couple of speakers weren't able to attend and were attending via video link. And I remember at the time thinking, okay, we're going to have to start sorting things out for ourselves. And I spent the afternoon basically texting people and emailing people to say, we need to sort out our services, actually, because I think this thing's coming to us. And at that point, we didn't really have much in the way of government guidance. By the next week, we were starting to get cases in the hospital. Staff were starting to go off sick and self-isolating. And we suddenly found ourselves having to make lots and lots of policy around how to cope and manage with this impending pandemic. And also we were getting, I have to say, our senior leadership team were fantastic, gleaning information wherever they could get it from, because it wasn't that forthcoming centrally. But and then also finding ourselves having to contact colleagues in Italy and Germany and people getting information from colleagues in China about what their experiences have been. And as Lewis has said, actually there wasn't very much about mental health, and I think people had kind of forgotten that mental health might be involved. And as it happens, the epicenter of the pandemic in the UK was Lambeth and Southwark. That's two of the boroughs that we serve. And so we, our first initially, and what was fantastic in a weird sense was that there was a real coming together, everybody in it together, the patients, staff, everybody recognizing that this was an unprecedented situation. We all had to work on it together and do what we could, and everybody finding a role and what their role could be, and doing the best at their role, and seeing if there's anything additionally they could do, like Philippa finding something for her to do. But it was fraught, actually. And, I'm of the generation of doctors who, when we first qualified, we were doing, the 110, 112 hours a week on call. And, just like, you do your Monday, Wednesday, Friday, then you'd be on call Tuesday and Thursday and everything else. And it felt a little bit like that again, actually, because it was just non-stop. So it was getting up past 6, 7 o'clock, doing emails, then having meetings. And by now, all power to the IT people who managed to get everybody remote access really, really quickly. But within the first week or so, we'd already had to close down lots of services. Loads of people were remote working, but it did mean that you were working from 7 and until 6, and then I would spend the evening writing a policy for the next day. So it was relentless, and there was no break, because it was 7 days a week. And but what kept everyone going was the real sense that this is something that we are all in together. And I work with lots of people who traditionally thought of as being quite antisocial. but actually they weren't, and they were really helpful and really kind to staff. And staff were, and so everyone, the people who were there, because lots of staff had to be were off sick or self-isolating or shielding, and so there were fewer people available to do the work actually, and it meant that those who were left, particularly the nursing staff, were absolutely overwhelmed with what they had to do, and also at risk of catching this this illness that we very quickly learned could kill them. And I work in an area where there are lots and lots of the staff are Black and from other ethnic minority groups, and it became apparent pretty quickly that there was something particularly problematic for Black people and South Asian people and other ethnic minority people. And of course, a lot of our nursing staff are from Black and minority ethnic groups, and there were real concerns about their physical health actually. And it really came to a head when one of our ex-colleagues, doesn't work at the morgue anymore, but we worked with him for many years on our ward. One of our ex-colleagues, only 53, died. And it was at that point people saying, this is really serious and it can affect us. It's affected us and it's affected us now. And then it became clear that most of the people who were, catching COVID, certainly at SLAM, were nursing staff from Black and minority ethnic backgrounds, that and those people who were having more serious outcomes were Black and South Asian people, Filipinos people, and it was really concerning actually. And I think then, of course, there was the killing of George Floyd, and the terrible thing is that it was just horrendous. And it's horrible that if you're Black, then there are a higher risk for you from COVID. Perhaps the positive thing out of it is that it meant that all those issues around systemic injustice and institutional discrimination and racism, which people haven't fully understood, those people who've understood it have maybe said stuff over years but haven't necessarily been listened to properly. For the first time, people are starting to listen in a different way. And it's meant that maybe for the first time we'll be able to make a significant difference, we hope anyway, to longer term outcomes. And this is for patients and staff as well, actually. So, I suppose my kind of feeling is that professionally, it's been a massive roller coaster. And it's just been hard work. Although it's also, I've got to be honest with you, it's been quite exciting and interesting because we've done some innovative things. Personally, it's been hard actually. It's been hard because it's tiring and overwhelming, and I'm quite sure that everybody feels overwhelmed by, particularly the way in which COVID has highlighted the significant discrimination that exists within our society and how that impacts on everyday life.
Thank you very much, Ladi. So, as you rightly say, in our organisation, we've been at one of the greatest, highest rate epicenters in the country, an area with really significant deprivation, poverty, exclusion, lack of employment opportunities for many people, and also a very, very diverse. I think across all our boroughs, there's roughly 40 to 50% of people come from all sorts of diverse backgrounds. So a really, really significant place. And in some ways, I suppose it's one of the reasons why Sean and the Maudsley learning team felt it would be good to have these challenging conversations, which is if in our patch we're able to surface some of these issues and how people dealt with it and people's real emotions that we need to understand better for the future, that would actually be of great service to planning going forward. So my question really to all of you is just one question, is what would you personally do and what would you professionally do if there was to be a second wave of COVID? If you were trying to advise, and I'd love to know who you would advise, would you be advising the Secretary of State, Matt Hancock? Would you be advising the Prime Minister? Would you be advising the Chair of the Trust? would you be advising? Who would you be advising? What big ticket things would you do if you knew a second wave was definitely coming around October time? Who'd like to kick off on that? Do raise your hand. Al, thank you.
Okay, so my advice would be to, I'm imagining you want me to pick one person that I'd like to give advice to. So since you are a Ned, Geraldine, I'll give my advice to you and the board. And my advice to the board would be, having listened to the staff, because we have systematically done a listening exercise where we've more rigorously than ever before noted all the themes that have come out of all the staff spaces that we've been involved with, and we've probably met with, you know, as a great many staff in a very short space of time to learn from their experiences. And three things have really come out as being probably the most the things that they're finding the hardest. And Laddie's already reflected on some of this at the moment. The first is that things are that things are unequal, that there is a fear of infection. We all have a fear as a result of this infection, but some people are more afraid than others, and they have a right to be more afraid than others. There is a disproportionate impact on this, and we need to be where people are at in terms of their fear, and we need to know our staff. So the first thing I'd like to say is, let's really listen to our staff. And I happen to think that the board has done a really great job of this. I think we have been hearing certainly the experiences of our Black and minority ethnic staff in a way that we haven't heard them before. And that's not to say we're hearing them enough or that we're acting quickly enough, but we are. But really moves are afoot, and that is a very important thing. And there are other people who fear infection, and I think that we need to give people space and in an ongoing way to be able to talk and process their emotions. The second thing I think that has been coming out is that because people have been moved around all the time, and that is necessary, as has been reflected on, you know, we have to change services, we have to shape our services in different ways, we have to separate out people who may be positive from people who we know are not for the virus, and that slows everything down. We have to move staff across from one team to the next. But that chaos is very destabilizing for people. It makes them feel that they don't know, they don't feel psychologically safe. They're not working with the team they're familiar with. They're not working with routines they're familiar with. And there's a great deal of pent-up frustration in the system. So I know that there are Laddie's reflected on service users being particularly helpful and friendly, and that's true. You know, some people have been absolutely fantastic, but there is also an increased rate of violence, and there are people who have been really frustrated by the system and the slowing down of the system. That takes its toll on staff in terms of how safe they feel. So my second message, I guess, to the board would be, make sure that when people join a new team, they have a clear protocol. They know what they're doing, and they're supported to do that. So I think there's nothing. We can't put too much energy into inducting staff into their new place of work, helping them understand what the standard routines are there, giving them what certainty we can. This is who you can turn to. So really concrete, helpful suggestions for each and every member of staff, because each and every member of staff matters. And then the third area, which I've already alluded to, which is this increased level of acuity, the fact that we are seeing people we haven't seen before, and we're seeing them in ways we haven't seen them before, with the levels of frustration that they haven't experienced before. Now, that's partly because our community teams aren't functioning in the way that they were before, and people are not able to access services in the way they could. And I think we need to be thinking about how we support our staff to support service users in a different way. And I would make a plug here for psychological therapies, because I think that we tend to have blanket rules in times of emergency. We tend to say, well, okay, all psychological therapists need to be working remotely. And I'm not sure that that's the answer. I think that we need to be thinking in a more nuanced way about who needs what, where, and when, and that is a big challenge for the board. So those would be my big messages. Listen to the staff, listen to the messages, and actually there is a fourth one, and the fourth one is exhaustion. I think people, and that's already been alluded to, I think people are shattered, and staff, service users, everybody's shattered. So can we slow ourselves down?
Thank you very, very much, Al. Philippa, I can see you desperate to say from an expert by experience point of view, you and your peers.
I guess I've got three points again. One, flu season. We're going to still have COVID. Everybody's coming in with a temperature. What are they going to have? It's going to be like rolling a dice. That's only something I know from being on the physical side of things, looking at it and thinking, yeah, that's going to hit mental health. So, yeah, maybe we might have the second wave, but it might as well be. Seeing a human being was the thing that I missed the most. I never saw another human person, and I didn't care whether they looked like a spaceman or not. Like I said earlier to Geraldine in the beginning, I was like, oh, no, virtual's better. But then after, I'm just like, no, I want to see a person. I haven't seen a person. I haven't touched a person. I don't know what it's like to have real contact with someone in the same room, because I've just been stuck here. And yeah, now I get to wipe a lot of bodily fluids, so I see a lot more. But that was the thing in the pandemic that hurt the most. And I was never told what services were open. I was only told which ones were closed. I was not told what to do if there was a psychiatric emergency. I was told what not to do. I was told not to go to A&E. I was told not to see my care coordinator. I was told not to do this, and I would not be getting results, and I would not be getting my regular blood results, which I actually need on my medication, so had to sort out somehow. And I would not be getting this, and not this clinic wouldn't be working, this one wouldn't be working. But I was just left at the end of it thinking, so you've given up on mental health because physical health has come along. And I've got a couple of friends who have sadly killed themselves. And I don't have friends that have died of COVID. My friend's dad, 73, actually survived it after being in ICU for a long time. But yeah, I know people who've died of suicide, and yeah, so that's the position that I'm coming from, that this terrible disease is terrible and it does kill people, and I know that, and I've watched my friend's dad nearly die. But the people I know who've died, of all ethnicities, yes, it's both suicide. But then that's probably my age group.
Philippa, thank you so much for those really, really meaningful words. I think that's a huge lesson and a huge learning for us to understand and take forward. And it's a theme that's come up throughout this conversation about when is mental health as important as physical health? And it has to be during a physical health pandemic as much as during peacetime, for want of a better word. Marcus, do you have any thoughts? You've listened, you started us off, thank you, and now you've been listening as a junior doctor. What would your messages be? What would you want us to take on board and change if we're planning for an October pandemic? Marcus, I think you're mute. Yeah.
Sorry, can you hear me now?
Perfectly, thank you.
Thank you. I think one of the things I'll say is that everyone everything everyone has said is very important, and I think it's using all of these different perspectives together at the same time. It's not either or, it's both and. And I always kind of like to think that we as psychiatrists are best placed to do this because we've already got training in working in a biopsychosocial model. We don't think of just physical health. We don't just think of the person's mind. We don't just think of the entire environment. We think about all of the things together and how they have kind of bidirectional effects, as it were, on each other. I've been very drawn to kind of what the academics call this approach of what they call intersectionality, which I guess ties directly into what Dr. Lade has said in terms of thinking about how all these different layers of inequality and disadvantage can overlap and kind of make something potentially entirely different together. And I mean, obviously we don't know, we know a little bit, but obviously we don't know that much. But I mean, again, as Lade said, and everyone has said, there has been a fantastic amount of learning in terms of what's gone on. And I think we as a trust, and also in Twitter, I'm sure everyone has said, the National Conversation has also said that we as a scientific community have really pulled together to kind of really kind of give some kind of statement on kind of what have we learned in each different aspect. So I suppose it is kind of pulling all these things together and kind of understanding what does that mean for the staff, because staff who are working in the front line with the physical health will have different needs from staff working in mental health. And again, kind of like, say, for example, there might be differences in race between these two groups, so different subgroups as well. So thinking of all of that, how it comes down together. And the last thing I'll also bat for what Dr. Beck said in terms of the kind of the top-down leadership. I think what really helped for our ward, where all that chaos was going on in terms of wards closing and all that, I think that's a really good point. Communication and certainty, in as much it can be given in a kind of pandemic environment like this, and kind of support to kind of work in the kind of a new environment and helping them to understand kind of, even though this is done destabilizing and all the rest of it, what new opportunities, as it were, can there be? That's what I'd say.
Thank you very much. And Lewis, we've heard the people talk, we've heard that the academic world pulled together, but we've also heard Philippa say, yeah, but the total practical, intellectually, we know about all of these things, but absolutely practically on the ground for people being seen, something different needs to be there for them the next time. And nurses will often be the people I know at the front line that deliver that. So what are your reflections? What would you want kind of a contingency plan for October lockdown to be?
I think it's something about almost process and the way that the system works. So there was a period during the peak of the pandemic where we became a high functioning health system, probably for the first time that the NHS has ever been. And that was something about how we work together as a network, and within that network is professionals, the community, etc., etc. It's vast, how that structure was harnessed. And we used the traditional hierarchy within the NHS to move through issues that were raised in the network and unblock those challenges as the structure should be. So I think there's something about, we hit a sweet spot for a few weeks there where it actually worked. How did we do that? And I think that, I suppose, having also said that, the other part of it, as Lade alluded to, was, is it sustainable to work how we were working at that time? And the answer is probably no. And I suppose that's where some of the work that Al led on needs to come in, and we need to make sure that we don't lose sight of that. We have to have the support structures in place to help people to get through these challenges and work in a way that enables them to get through these busy times. But we have to be able to harness the system in that way and have this sort of high functioning networked approach, which I think unlocks the solutions and the knowledge that is naturally there. Which is quite often hidden.
Thank you, and I suppose it's one of the aims of this challenging conversation series is that we don't just look at one perspective. We don't just ask for one profession or one group of people. We are bringing together throughout the series partners from different parts of the system. And I think you're all right. How do we continue to have that dialogue? How do we surface a way to develop, for want of a better word, a real contingency plan that actually takes all these perspectives together? Is that partly what the power of digital can do, as well as digital difficulties and challenges? Laddie, what about for you? I know you're exhausted, but we'd love to see you having a really good rest somewhere. So what is there for you? What would you do different as a clinical director the next time? What would you want to see very practically, things being different? Is it too early to process this? But for you at the moment, what would be different?
Well, I think what I would do that was different from last time is to accept that actually it's highly likely that there's going to be a second outbreak. Better to, prepare for the worst, hope for the best. So I'd be saying to central government, please, just assume there's going to be a second outbreak and provide us with the infrastructure that we need. So making sure that there is going to be enough PPE, making sure that there are going to be enough beds, etc., which they can do now. On a central national level and on a local level, I'd be saying, as Alice and everyone's mentioned, you really need to attend to the inequalities, because what's been writ large and highlighted is that there are these stark inequalities, and if you don't start attending to them, it's not about attending to them in the time of COVID, it's about attending to them full stop. And that's not just about racial inequalities, but it's also about the inequality between mental health care and physical care, actually. And I think Philippa said it very, very, very eloquently. Look what happens when you don't attend to people's mental health. They still die. And this is really important, because we know that the most severe mental health problems affect young people. I would certainly say that I think this is mentioned again also by Philippa and by Al, you've got to be flexible in your approach. You can't have one size that fits all. And funny, that links in with the inequalities again as well, because we know that there tends to be are you white, British, or straight European, or are you not, other, as though all black people are the same and all Asian people are the same and all South Asian people, and it's not that. And likewise, the way in which people feel able to take up mental health care or deliver mental health care is going to be different. So some staff took to remote working brilliantly. Other staff just really find it hard. Likewise, there'll be some patients who quite like sometimes having a remote appointment with their care coordinator, but actually at other times they'd just really like to see their care coordinator physically and be able to see them face to face. So there has to be flexibility, and there's room in the system for that, actually. Lewis's point about us, I love that term, finding the sweet spot, and it's true. For about 4 weeks, it was like a machine, a really well-oiled machine, but it was exhausting, and it wasn't sustainable. I think there's work happening locally to try and find that sweet spot, and how do we build the infrastructure so that we can get to that sweet spot more regularly, and that work just needs to carry on. It would be good if central government recognised that that was possible, that they were to support local services, local trusts and local providers, listen to the local providers and use the policies that we have instituted and developed to then decide how they should go about funding the services, actually, because it's fundamentally from central government, it's about how you fund the services, and what they need to be doing is listening to local providers a bit more, because I think that was what ended up working anyway, because we were developing policy before the central policy was coming down.
Okay, I think what I've heard from the conversations is just very, very good insights about the messages you'd want to give to the Secretary of State, the messages we'd want to give to our central systems organisations, messages you want to give to cross boards. I'd love to just finish with each one of you saying, just really quickly, what will your biggest resilience be for yourself dealing with this COVID pandemic in the future? Philippa.
Biggest resilience tip, find a job, whether it's cleaning bedpans, and yeah, just not sit at home with no routine.
Okay. And I know that we can show afterwards. Philippa on Twitter wrote what I find probably the best top tips for resilience in the entire sphere. So
do something you enjoy, get outside for a walk, do something that makes you proud of yourself, have a routine, relaxation.
Thank you. Lewis, your top tip? Personal?
I think it has to be getting outside. I think about if I didn't have access to a garden, I think I really would have struggled through the lockdown period, and and exercise has to be there as well.
Fantastic. Al, what's your top personal tip? You're on mute, I think.
I was going to say take a long, hard look at myself, because I was going to say running has been my saving grace, and I've run and run and run, and now I'm running much too much. So I've fallen foul of the same thing I always fall foul of, which is trying to do too much always. So I'm going to replace running with being kind to my children, because in fact you can never do too much of that.
Perfect. Marcus?
From a personal standpoint, I will say that social isolation is not always a bad thing. It can be a positive experience. There are positives to the fact that, for example, you can, take your time away to reflect, a break away from, the hustle and bustle of busyness and all the rest of it. But again, it's never a one-size-fits-all approach, isn't it? Because sometimes when people take a break, people take a break from work, there's stresses at home as well. So I wouldn't say that without caveats, but for myself, I think definitely the time to kind of reflect and take time to myself, that's been very helpful.
Perfect. And Lade, last word?
Very quickly, I'd say if lockdown happens again, long walks with audiobooks and online Zumba.
Yes!
Fantastic. Fantastic. Thank you so much indeed. You've been an amazing set of panelists. I thank you so much for sharing your stories, your insights, your experiences. Thank you so much. Do take care. See you next week on the 30th with a new panel. Bye.
Thank you, everyone. Bye-bye.